Um, I used to be a professor at UCSD for medicine, as well as a clinical instructor for UCLA, adjunct professor. I also did for the medical board as a medical board consultant for the state of California. I do have my own urgent care and in the border city between Calexico and Yuma and San Diego area, in which that I had observation of teenage problems in different areas of the United States. I will also like to introduce our county, which is 180,000. Our county actually was California COVID death capital. The population of the city where I have my practice is 38,000. And the reason for me to have a desire to help with teenagers is my son's story, in which that he was in last year of medical school, and his observation why teens in different areas of the United States do shooting, why the teens in areas where they are close to the roots in Mexico, they have less behavior. And that actually was a desire for me to go after the information. So in actually a retreat to actually retribute to his memory, I decided to do the research, and that was really my desire. In 1 month, I provided informed consent to adult primary care patients during normal clinic visits, and explored how a patient ACEs, which is adult childhood experience, affect the diagnosis of anxiety, PTSD, depression, eating disorder, and bipolar disorder. The results of enrolling 57 adult patients, the median age was 37, over half of them were females, 89% with white Hispanic, and most had diploma for GE or college degree. And out of the statistics that was provided, over half of the participants, they had 56% with SDOH score of 60 to 69, food insecurity and reliable transportation and stable housing also was one of the domains. The largest number of participants reported score of 5 or less. One of the major information that was seen was just reliable transportation, stable housing, immigration status, neighborhood environment. Of the 57%, 38.6 had not been diagnosed with any of mental disorders, but 5% reported diagnosis of all disorders. Depression, bipolar disorder, eating disorder, PTSD were more common in participants who reported more than 3 ACEs. Of the 22 participants with 3 or more ACEs, the majority had depression and anxiety. It was interesting to note that anxiety was more common in participants with less than 3 ACEs, including 3 participants who reported an ACE score of 0. Interesting, depression and anxiety were more common with participants with SDOH score of 50 or higher. PTSD, however, was more common in participants with SDOH score below 50. Looking at some of those results, what is the prevalence of social determinants of health participants diagnosed with anxiety, depression, PTSD, eating disorders, and bipolar disorder? And looking further in the information, it was noticed that the JAT7 and PHQ-9 were not included in the survey. However, the participant did indicate if they ever had received a diagnosis of anxiety or depression. Two sample tests were performed to compare A score in participants who have been diagnosed with anxiety and those who have not been diagnosed with anxiety. There was a statistic significant difference in between the groups with anxiety diagnosis, the mean variant 3.89. Those without an anxiety diagnosis, the mean was 1.82. And a two-sample test was performed to compare ACE participants who have been diagnosed with depression, those who have not been diagnosed with depression as well. There was a statistically significant difference in between the groups with a depression diagnosis and those without a depression diagnosis, with the mean variant of 4.07 SD 2.65 to the other comparable SD 1.53. And the discussion, though, at the end, the family support and proximity to others were missing. The benefit actually included the ACE question into the intake process. I have learned a lot about my patients and their families and the challenges they have. I also noticed in some of the groups that I did compare together, one of those groups, for example, there were a family of the grandmother is the main person who's taking care of the grandkids, and her kids are actually held in jail in Mexico. And it was noted that this lady, with little help, that she managed to raise at least 20 grandkids on her own, but she has her immediate family like sisters and brothers who helped her with her problem. In the same family, she has cousins who actually live in Los Angeles, and this family did not do well as this family, despite of the poverty of the family that it is living here. While the family in Los Angeles were able to maintain better lifestyles, but their kids were involved in mafia and shooting and other issues. The lesson that I've learned from it is we're losing the matrix and we're losing a proximity to each other, and being having extended family to live together, even though that it is considered against most of the rulings, I found that is actually helpful more than unhelpful. And that basically was the lesson that my son was trying to tell me over the years, that he enjoyed it when his grandmother was here. He felt more warmth, but when the grandmother was not was away, that made our relationship being distant apart. Um, in that, I just started to turn one of the old hospital building into a Calexico community center, in which that I am doing my project of teaching the teenagers into having more art classes and coordinating with the schools of having the teenagers more involved, as well as having them to be having more lifestyle in the situation. I also wanted to point out part of the information, the pyramid that I used if, for diagnosis of the adverse childhood experiences, the influence of health and well-being, and it was noted as generally historical trauma is the major event that caused the problem. Social condition was the second issue. Adverse childhood experiences, like, for example, kids that they had separated parents, out of those results, yes, that I'm just looking into them, that they had many traumatized events like separated family, kind of one of the incidents of a boyfriend to the mother, or etc., disrupted neurodevelopment, that the kid would be separated from both parents. That led to a lot of those social and emotional cognitive impairment, which is really kind of one of the issues that was noted. Adoption also of health risk behavior, disease, disability, and social problem, early death of a family member. You all these contributed, but the major event was just the historical trauma. That mainly was the biggest factor that led to the adverse childhood experiences, created the trauma in most of the history of the people that, or the patients that I came across. Also interesting that most of those patients, they were my patients for more than 30 years. That's why it was so easy to collect the data about them, because several of those patients were, I've known their family, I know their life history, I know their disease pattern, so it was very easy to collect information about them. Another factor that I've noticed in most of those patients, that poverty really was not the major issue. It just kind of more that it contributed to the situation, but mainly was the traumatic event, the loss of a parent, the no continuity, no proximity to the roots. That led to a lot of separation in the mind of those children, and the parent, or like just seek somebody else to help. I remember when I gave the presentation in the University of Arkansas, I remember very well that many of the audiences have asked questions, because that research was done on behalf of the University of Arkansas, and I did actually my fellowship with them for good medicine, and I would just say that I contributed. I do enjoy so much the studies that was done by other participants, but I remember one of the audience have stated that she doesn't have family members around, and what would she do, because she feels that in a way that causing, there's like a distance of the family and distance of events and continuity of love and care. And so I actually advised her, I'm an immigrant myself, and being far away from my family, being in an area that it is, I've been here for 30 years, it helps so much to be able to create your own environment where you are. And that's mainly what I would advise. Like, if not all of us are close to our family, so what are we going to do? The best to do is just to create our closeness by having first of kin or friends, that sometimes could be better than having family support and proximity to others. That should be kind of like, that's why I'm trying to do a program in which that talking to teenagers in between those ages, and try to help the families, that there is a create, actually proximate the gap between them and their family, and to create a bigger understanding with them. I believe that is the end of my research and information. I thank you very much for time, and I would be open for